Dr. Bemis. Next, I'll call up Dr. Haywood Brown, who is the past president of the North Carolina OBGYN Society. He's the chair of the Department of Obstetrics and Gynecology at Duke University School of Medicine, and he's a professor of obstetrics and gynecology at Duke.
Thank you very much, and thank you, committee, for allowing me to have some time with you to address some of these issues. And I'll be happy to try to answer some of your questions, and particularly your questions related to family physicians, and also with some of the requirements and so forth and so on. I am in Durham, and have been at Duke. I'm a lifelong North Carolinian. I was born in the eastern part of the state, and I was delivered by delivered by a family physician, and he did a good job, I hope, and took good care of me. I'm also a disparity researcher, so when we start talking about infant mortality, I'd like to pick up on this. Now, my whole research life has been on infant mortality and maternal mortality. I'm on national committees for it, and I will tell you that I will make one statement. It is not as simple as anyone having independent practice. It's not that simple. You've already heard that the leading causes of infant mortality in the state of North Carolina are, in fact, prematurity and congenital anomalies. But the infant mortality rate for term healthy newborns, regardless of setting, should be about 0.2 per thousand. So you can see that this problem of infant mortality is not going to be solved by who practices and how they practice. So I'll address that later. Now, from the perspective of this, I represent the American College of Obstetricians and Gynecologists. I'm the district chair for ACOG. The president of the American College of Nurse Midwives is on our board, and I would like to, if you want me to clarify some of these statements that Mr. Miller has read, I'd be happy to share that with you at some point. And I don't think this committee has time to do that. If you could go back to the map, I have practiced I trained in Georgia, where we had the same arrangement as we have now, along with midwives. I practice every day along with midwives and nurse practitioners, certified nurse midwives. I practice in settings in Indiana with family physicians who took care of obstetric patients, as they do in the several counties of North Carolina, sir. And I know what the arrangements are with regard to the obstetricians who work with them in a collaborative manner, as we do with our nurse midwives. And I would share with you the fact that anytime anyone runs into a complication, that need to have someone there who can handle those issues, regardless of who the delivering clinician is. There are certain requirements and expectations that need to be met for quality and safety. But let me also say that obstetricians and family physicians who practice obstetrics are committed to supervising nurse midwives who provide basic, normal perinatal care consistent with that training and scope of practice. And I don't want to leave out the scope of practice issue, because these are the things that we've worked on with the American College of Nurse Midwives. And again, scope of practice, regardless of what I do. I am not a cardiologist. I'm an obstetrician gynecologist. And so if I need resources for my patient who has heart disease, I'm going to get the person there to take care of it. Normal obstetrics. Normal obstetrics. And we can talk about what normal obstetrics is. These are not my guidelines. These are guidelines for perinatal care established across the country. There are many OBs across this state, including our society president, current society president, Dr. Lindsay Stevens, who practices in Elizabeth City, who would welcome having certified nurse midwives as part of their practice. Welcome. In fact, he looks for those individuals who are willing and want to be part of his practice. And this is the relationship that ACOG has established with our nurse midwifery colleagues. We want to work with them to provide care for the women of this state and any other state. So to suggest that we don't want to do that in a collaborative manner is not the case. Obstetricians support certified nurse midwives practicing to the full extent of their training and licensure. Let me be clear. Let me be clear. We do support that on a national level, on a state level, on a local level, as we do with family physicians who practice obstetrics. When they are out of that realm, we're there to collaborate and to supervise as we need to. I want to also talk about the position statement that by midwifery from the American College of Nurse Midwives approved in 2009. Their standards for practice of nursery requires a certified nurse midwife, and I will share with you what a certified nurse midwife is. All midwives who are not nurses. Certified nurse midwives are nurses. Certified midwives have a degree, an advanced degree, and have training in midwifery. Am I correct? That's absolutely the case. And those people are clearly licensed and recognized by the American Academy of Nurse Midwives. Demonstrates a safe mechanism for obtaining medical consultation, collaboration and referral, participate in a program of quality assurance and peer review, practice in accordance with the legal and disciplinary requirements of the jurisdiction where their practice occurs, and shows evidence of continuing medical education. That is from this joint statement that ACOG and the American College of Nurse Midwives have together. So we're not against each other. We're talking about what's in the best interest of the women that we're trying to serve in this community. I work alongside nurse midwives every day in the capacity of a collaborator or a supervisor or whatever you want to call me. And I was just on call this holiday. Patient rolls in. She is having her third baby. The midwife has seen her. We get a call, and the patient is having a baby with a complication, with a shoulder dystocia. I'm in the room. I'm working with her. We deliver a healthy baby. Now, you could say that that I was not the person who had my signature on the paper as her supervisor. But I think that's kind of a misconception about what we do. If there is another detailed provider in the room, as it was in Mr. Miller's case that he's aside, that could have been there to help, to champion his child through a healthy birth, if the need was there. So to suggest that his supervisor was somewhere home in bed, that was someone of his partners was certainly there in order to be able to help that outcome be what it needs to be. And that's the objective. That's the objective. Physician supervision helps ensure the training gap between physicians and nurse midwives, as with family physicians, are addressed in practice settings to direct decision-making for the benefit of the provider and obstetric care for the women we are committed to take care of. That's the objective. That's the objective. It's not meant to limit anyone's practice, except when those practices deviate from the normal. And as you said, like many physicians who would deviate from their scope of practice. Certainly, we know that there are individuals who practice midwifery deviate from that scope of practice. You can't get away from that. That's the reality. Individual practitioners, whether they be MDs or certified nurse practitioners, should establish a collaborative relationship within the context and structure provided by the laws and government of the state. I've already talked about my personal experience. I practice in Georgia with nurse midwives. Always have, always do. I was in Louisiana with nurse midwives. We have a collaborative relationship as well. I spent 13 years in Indiana, and we took care of 5 community health centers, practice settings, where nurse midwives and nurse practitioners work alongside us in delivering care to the women we prepare to serve. We're not that different in the state of North Carolina. I'm back down in my home state, and I have a vested interest in making sure that we do attack those implementality, but not from the perspective that we're talking about. So, 28 states across the country have physician supervision requirements for certified nurse midwives, similar to the current laws in North Carolina. Unlike what we presented there are 28 states. North Carolina is not in the minority. 20 of those states require a detailed written agreement. Now, what's been misconstrued here is many states define collaboration in the same manner that North Carolina currently defines supervision. Not my words. That is the case. And to suggest that only 6 states that, quote, have independent practice is misconstruing what the definition of collaboration and supervision really is. Because there's a cross communication between those things. I will tell you this, there are also 2 states that are currently trying to undo the legislation that they have done because of the damage that has been occurred. And that includes the state of Maine and the state of Oregon. So if you want to look at what's really happening, some of the legislation, and I won't call it that was done, is now being undone for the benefit of the health of the mother and the child. Now, I'm going to finish up in a minute. The system is not broken with the current arrangement of supervision, formalized backup of physicians for the anticipated complications that can occur in the management of normal labor and delivery. The patient who rolled in our setting, was normal labor and delivery, having her 3rd baby. I don't think that my nurse midwife was unhappy that I was there. I don't think the patient was unhappy that I was there in order to be able to talk, to champion a normal birth. Deviations from the scope of practice, regardless of setting, certainly in the home setting, has been consistently shown to endanger the health and safety of both mother and baby. Previous recent studies demonstrate a high infant death rate and neurologic injury rate for planned out-of-hospital birth. And I would, if you want a copy of this paper, I would encourage you to read it, because the cost of care for a neurologically damaged child to the state of North Carolina is over $1 million. That's what costs Medicaid. That's what costs you. And so this looks at all birth settings, including birthing centers. So that's the issue. Deviations. Hospital transport is needed for 40% of first timers. To answer your question, yes. There are nearly 4 times as many obstetricians serving rural areas of North Carolina compared to the number of nurse midwives. And the overwhelming majority of women in the state of North Carolina and rural communities do not have a logistic barrier to obtaining the best and the safest obstetric care. That is enough.
Thank you. Questions? Is it Babylon?
Yes, ma'am. I'm against this bill. Yes. Yes.
Senator.
Thank you, Madam Chair. Dr. Brown, thank you. You may know, I'm very familiar with your work, financial supporters programs.
Yes, you have indeed. We appreciate that.
But I do think, I'll speak for myself, not for anybody else, but I think we would all agree that infant mortality is not going to be solved by one of these issues. There is no silver bullet or magic wand regulatory perspective. So this is one small piece of the whole infant mortality rate, and I think my concern is prenatal delivery and postnatal care. So trying to get the collaboration piece of this that you focused on. Training, you mentioned, you made a point on. So I'd like to hear a little more about that. I had an experience talking with a certified nurse midwife. This is an area where we can have some conversation and more dialogue. The certified nurse midwife did not meet the position to sign her form for the licensed her until they met and the physician signed the form. And if training is important here, then the current system is broken in that we allow physicians to simply sign without through, going through the training you're suggesting. And so I'd like to hear more about how there could be collaboration leading up to that supervisory role and what you would do afterwards.
Well, let me give you an example, a perfect example. Having come from St. Vincent's was my hospital in Indianapolis, which was a collaborator with the university, where we had family physicians in both places and nurse midwives. So here's an example. I'm currently the signature authority for almost all of the physicians and nurse midwives, even though because I know what their credentialing and their training is. When a family physician had a patient that he was following in labor, what he would do is to say, Dr. Brown is my backup supervisor in the event things deviate from normal. Now, what that meant was that I would come in and maybe write a note on the chart. I would be familiar with the patient, and so that if I wasn't there, one of my colleagues was there. But I knew exactly what that patient was about, and I knew what potential risk she was in. And that's the same thing with the nurse midwives that we work alongside every day. And so the idea is that we are collaborating in the care of that patient, and that's what it means. Now, you might say that that supervising physician is not on site. Well, and you talk about the fact that 98% of the births by midwives and by physicians are done in the hospital. Well, what happens is, if that person is not there, one of their colleagues is there if things deviate from normal. So I think that that's really the distinction. So there is a gap in training. There's a gap in training, just as it is with me and my resident physicians who are doing deliveries, and my family physician friends who are doing deliveries. And I've always felt comfortable with the fact that they knew what was coming. One of the problems that we have with any of this, is when we deviate from the scope of practice. We present statistics on VBACs and stuff like that. Well, I will tell you that there are many physicians and many states and many hospitals don't allow anyone to do VBACs because of the risk of uterine rupture and adverse outcome. So to suggest that they are just as good in the hands of any individual is just absolutely false. Delivering twins is not for the faint-hearted. It's absolutely false to suggest that the outcomes, depending on the level of expertise of the clinician, doesn't matter. It does matter. And so those are the issues that I think that we need to talk about. So even in normal birth, everything expected to be normal, things can happen. There's a reason the textbook is this thick. There's a reason it's this thick. It's not a manual. It's not a how-to-do manual. That's the difference.
Sure.
Right. That's helpful, and I may be looking at this clear. To me, it seems, I think you would agree, and most of us would agree, that training is an area there can be a lot more conversation about.
Absolutely.
A lot more collaboration. I'm also concerned that training is one of the issues driving this is something I think. And I think it is something that can be improved about the process.
I can address that because, again, most of us in medicine, obstetricians, family physicians, feel very comfortable with the training that certified nurse midwives and certified midwives have. And I don't want to have this confused with what many states are grappling with right now, including the state of North Carolina, with professional midwives. Because I can read you what the international definition is for a trained midwife, because someone asked that question. I actually happen to bring it with me. And it describes the training. That's a different set of circumstances. I feel very comfortable with the training that my certified nurse midwives and my certified midwives have had to stay within that scope of practice.
Now, you talked about you worked in Georgia and Indiana, states that have different approaches than North Carolina.
Who have?
Georgia and Indiana, two states you've worked and practiced in.
Absolutely.
You worked alongside certified nurse midwives there, and the setup of collaboration is different. Could you outline what those differences are?
Well, actually, it's the same thing we have in North Carolina. It's collaborative.
Signatures required?
It's signatures required. Yes. Yes. A signature authority is required. And so when we talk about that,
so you're saying that there are no differences in that relationship in Georgia?
Well, let me just say that
what you're experiencing now in North Carolina.
The experience in North Carolina is that there are certain the independent practice, the supervisory and collaborative agreements essentially make some of them the same. And there are about 20 states that have that same designation with signature authority. And so what I'm trying to say is that signing something in a collaborative state is not that different than signing something in a supervisory state. So when you talk about independent practice, you know, that it's miscommunicated. And I don't want you to be, I want you to be clear about those 28 states. If you were to go back to that map and look at it, you can talk about the states that have collaborative practice. 20 of them have signed agreements. Some of them even more stringent and more restrictive than what we have now. Yes.
Representative Babel.
I'm giving message that makes sense to me. 20 states that have collaborative the statement that you made was that they have very in-depth contractual agreements.
Yes.
Do those states allow a certified nurse midwife to have an independent practice?
No. They do not. They do not. 20 states require detailed written agreements. And so many states define collaboration in the same manner that we're describing supervision.
I was going to ask
But
you
they ask that question.
give us a definition,
Yes.
your definition of supervision versus collaboration.
Right.
What's the difference?
Many states keep them basically, it's like a smooth line, but there's a signature agreement with who that collaborator is for the same thing that nurse midwives want, to ease access to consultation, collaboration, and referral. You got to know who you're going to refer your patient to. That's what the signature agreements are about with groups. That's what it is. Who's going to take care of your patients who are not normal, healthy, etc.? Yes.
Under those detailed collaborative agreements, do you as a physician working with that certified nurse midwife have physical liability?
Yes.
Professional liability.
Yes.
Professional liability?
Yes.
Do the nurse midwives have separate professional liability insurance?
They do have a separate professional liability. Yes.
Have you seen a dramatic increase in the cost of professional liability lately because of nurse midwives?
Well, in my setting, it's not. In my setting, it isn't because of the relationship we have. It's not. And because I trust them and they trust me. And so in reality, I would say that in our setting, our liability for the first time in years, and I just went through this yesterday because this is what happens, has gone down. Why? Because we are practicing within the standards and the scope of practice that we should be. The reason that you lose supervisors, as I would, is if someone was rogue in that practice.
I'm asking you one last
Yeah.
question. You look at this map of us. This is a map where there are no OBGYNs in the light yellow area and very few OBGYNs in the orangish area. How do we get someone there to deliver babies?
Okay. Well, let me just say from a prejudicial perspective, I'll put this out here right now, that the majority of babies in this in the state of North Carolina, majority of babies in this country are delivered in hospitals that have less than 500 deliveries. You might ask me whether I'm a big fan of that. I don't think it's in the best interest of women or children to be delivered in a facility that only has one delivery a day. So, let me just, and I make that very clear. I'm not the only person with that opinion, because I don't think it's safe if you only do one delivery a day.
Sure.
So the issue of these rural states, and I know my colleagues around the country, I will give you the information from the Shep Center. There are 4 times as many obstetricians served in rural communities when compared to the number of nurse midwives in the rural areas. I would say that we know that logistically, there's not a single county and not a single patient who is not within a certain logistic area of a hospital where they can provide, can be given care. And maybe I would say that some of these communities probably ought not be delivering babies, but that's my opinion.
Well, and I understand that opinion, that they're close enough
Yes,
to a hospital.
absolutely.
But are we, according back to Senator Woodard's
Mhm.
recommendation, are they better off being delivered by an emergency room doctor or a family doctor or at least a nurse midwife?
Yes, if that's done in a hospital. And I would tell you to go back to
A nurse
the-
midwife in a hospital?
Yes, indeed. If you go back to this paper and look at this that talks about setting and outcome, you can't get away from this data. It's real. This is national data. It's real. And we have data in North Carolina. So you want to talk about home birth issues.
Well, and we're
We
not
can
really
skip
going to
a
talk
story.
about home birth issues,
Yeah.
but if we had a nurse midwife in this area over here, where's her supervising physician going to be?
A supervising physician is going to be whoever is there, regardless of setting.
Not an
Could-
OBGYN?
Could be a family physician. Keep in mind, family physicians who practice obstetrics, and they have from the beginning of the time. I was delivered by one, and did a very good job after with the test. Can indeed, if they do obstetrics, can indeed supervise those individuals.
Representative Adler?
Any medical provider who does obstetrics. Yes. Family physicians, many family physicians do obstetrics. They have training requirements for obstetrics.
Ratings for insurance premium,
Mhm.
isn't it the fact that premiums for a bigger physician are lower than a bigger
Yes, they are.
So there is not a doctor and doctor nurse on sign raises insurance premium. Am I wrong?
Well, you're assuming that if they are supervising a person who stays in that scope of practice and doesn't get into trouble, then I would say there are many physicians who will sign it. I sign all the time.
You are.
Yes. Well,
And I'm
I
just
just
gonna-
told you my insurance premiums went down. It's not as high as they were certain.
Let me tell you, I'm just reading, the certified nurse midwife currently can engage in the practice under the supervision of a physician licensed to practice medicine, but he also has to be actively engaged in the practice of obstetrics.
Absolutely right.
So if you've got 500 babies being born with 3 GPs there, if you're not actively engaged in the profession, you've got less than one baby.
Well, I'm saying that that's the standard in this
It is.
country.
It is the standard.
It is. It is the standard in those communities that deliver babies. You know, there are hospitals that deliver one baby a day. Now, again, you may say that that's, and I think that's fine for that community. I don't think that I want to be in that setting. But I know plenty of family physicians who are practicing in this state and in other states who are doing 30 deliveries a month,
Any further
along
questions?
with their midwife colleagues, by the way.
Any further questions for Dr. Brown? Thank
You
you
have
for
independent
coming.
birth centers that are having this.
I'm sorry?
There are at least a couple of our independent birth centers
Absolutely.
that are producing those kind of numbers.
Absolutely. Yes.
Thank you, Dr. Brown.
Thank you.